Hello, everyone. My name is Ahmed Mohamed. My pronouns are he, him, his, and I'm a community organizer at the New Pride Agenda, an LGBTQIA statewide nonprofit organization focused on advancing the rights and protections of queer New Yorkers through education and advocacy. NPA has been hosting a series of virtual town halls since April 2020, and today's event, All About PrEP, is a part of that series and co-sponsored by our terrific friends at Amida Care, a nonprofit community Medicaid health plan designed to provide specialized, coordinated care to New Yorkers who are affected by HIV. I would also like to take this time to make a programming note about MPA's upcoming virtual town hall on Thursday, January 28th, where we'll be using the proposed state budget to inform a lively discussion about queer legislative and budget advocacy strategies our community can organize around to affect change this new year. Like I said, today we'll be discussing the benefits, access, dispelling myths, and talking about support resources throughout Brooklyn related to PrEP, a once daily pill that protects from acquiring HIV infection. Before we begin our discussion, I'd like to introduce our amazing panelists for today's conversation and ask that they introduce themselves, their pronouns, and talk a bit about their work or experience as it relates to PrEP. So first, Alister Rubenstein is the Transgender Health Program Manager at Amida Care. Alister identifies as a queer and non-binary survivor. They have been working in social services for 14 years, advocating for and supporting marginalized populations, including people with disabilities, people living with HIV, and transgender people. Alister is an artist and activist living in Queens, New York with their spouse and two cats. Hi, Alister.
Hi, my name is Alister. My pronouns are they, them. This is Wiley, he, him. And you'll probably see cats floating around. But as I said, I work at Amida Care. It's an HIV special needs plan. I've been there for about 6 years. And during that time, the Department of Health expanded the model of care to include other individuals that are put at high risk for HIV acquisition. So we've had in 2017, a whole bunch of transgender individuals negative, particularly trans women of color, enrolling our plan. And that's when we really started to amp up our HIV prevention services. So that really looks like creating an assessment, assessing our members, making sure they're aware of PrEP and PEP, connecting them to PrEP, and then monitoring adherence if that comes up. So that's what our work with PrEP looks like. Great to be here. Thank you.
Awesome. Thank you, Alister.
I would like to add that Alistair's got the coolest tattoos. Everyone that I know.
Thank you.
I love that. Awesome. Next, we have Dr. Jesse Ramon. Dr. Jesse Ramon is board certified in internal medicine and is an HIV specialist accredited by the American Academy of HIV Medicine. Dr. Ramon obtained a Bachelor's of Science degree in biology from Brooklyn College and his medical degree from SUNY Health Center at Brooklyn. He completed his residency training at Beth Israel Medical Center, New York in 2001. Dr. Ramon brings to BMS over 20 years of extensive experience in healthcare in the HIV field in New York, both as an HIV specialist and internist, as well as a dynamic background in research in the HIV field in large hospital systems across central Brooklyn. Hi, Dr. Ramon.
Good afternoon, everyone, and thank you for the invitation. So I'm currently at Brownsville, where I oversee our HIV and hepatitis C programs and also our PrEP initiatives. And we actually do have HESA funding to really help us expand PrEP use. I look forward to actually having discussions about some of our observations, but also some of the opportunities that we see, particularly in Brooklyn, but overall in New York City, in increasing PrEP uptake in various populations that currently are being represented in terms of PrEP utilization.
Thank you, Dr. Ramon. Next, we have Jawanza Williams. Jawanza is a Black radical queer prison abolitionist socialist community organizer. After he received a BA in English from Schreiner University in 2012, he moved to New York City, where he now works with the political organization Voices of Community Activists and Leaders, otherwise known as Vocal New York. Jawanza, hey, welcome.
Hey, Ahmed. Hello, everybody. Thanks for being here. So just really quick, my name's Jawanza. I use he, him pronouns. And today I'm the director of organizing at Vocal New York. I'm also a person living with HIV. And I should say that Vocal New York has been around for 20 years, formerly known as the New York City AIDS Housing Network, founded in 1999 specifically to address housing insecurity and other social determinants of health connected to people living with HIV across New York City. Since then, we've expanded to work on, ending AIDS as an epidemic, homelessness, mass incarceration, and the drug war and its consequences, overdose, and the hepatitis C pandemic. And I guess my sort of connection, almost immediate connection to PrEP as a person with HIV, I don't need PrEP, I'm on ARVs. However, when I first started working at Vocal in 2015, I was organizing a LGBTQ youth organizing project called Queerocracy, working to end youth homelessness across New York State, because we understand the connection between homelessness and LGBTQ identities and proximity to HIV and a host of issues. So I learned a lot that way. So a lot of my work is lesser about providing direct service and much more about ensuring that the socio-political environment that our people are living in across New York State allows for them to access, comprehensive medical care, and that includes access to pre-exposure prophylaxis.
Awesome. Thank you, Jawanza. And we definitely hope to talk about how interconnected all of these issues are throughout our discussion. Next, we have our final panelist, Jako Douglas-Borren is the Director of Programs at the Brooklyn Community Pride Center, where he services Brooklyn queer residents and supports the center in its growth, working with staff and the community that is close to his heart. Hi, Jako.
Hello, everyone. Thanks for having me. My name is Jako Douglas-Borren, he, him, his. You might hear a slight accent. That's because I'm originally from the Netherlands. I moved here about 16 years ago to study at PrEP and sort of stuck around. I worked for 40 years for Bed-Stuy Restoration Corporation, overseeing programs and services there, social and workforce services. And now for 2 years with Brooklyn Community Pride Center, running programs and services here. I currently reside in Bushwick with my beautiful husband, Sergio, and our 2 dogs, Halo and Brandy. They're slightly annoying because they require our continuous attention, but they're too cute to deny them. So in offering our service, Brooklyn Community Pride Center works with community members who are experts in their own right, as well as with organizations who have experience in offering services to the LGBTQ plus community. And together we offer a wide range of services. Most of what we do is currently online. You can engage in one-on-one coaching to work on your career, workshops to explore your creativity, various support groups. We have classes, physical activity classes, and much, much more. We're also open. Our physical location is also open Mondays to Fridays from 12 to 5. So folks can come here to just hang out, to be away from home for a little bit, meet up with a friend, or schedule an appointment with one of our staff, all observing social distancing and COVID-19 safety protocols. And we also have a free pantry with personal care products, so people can come here to take whatever they need. As far as PrEP, we partner among others with the Latino Commission on AIDS. They are here on site. They have an office here on site, and they're here Mondays, Wednesdays, and Fridays for PrEP counseling and HIV testing. We also work with NYU Langone and Turning Point, and they have a mobile van here outside on Thursdays from 11 a.m. to 3 p.m., as well as a number of other organizations. And personally, I'm also a faithful user of PrEP, and I can honestly say that since I started PrEP about 1.5 years ago, I've never missed a single day. So I'm very proud of that.
Awesome.
Thanks for having me.
Thank you so much, everyone. And so before we begin talking about PrEP and all of its benefits and getting into the details, we first want to establish the 3 principles of our community agreement to ensure a safe and welcoming environment for discussion. We hope that this is an engaging and interactive discussion. So we encourage audience members to comment in the chat box or ask questions that will hopefully integrate to the panelists throughout this event. But of course, we have to have mutual respect for each other, and everything that's shared is confidential. And lastly, when we're sharing things about our observations or how we feel, we ask that people use I statements explaining those things. I feel, I've seen, I've heard, just so that we're all ensuring that mutual respect. But yeah, so without further ado, let's get to this content. I would like to just begin simply, in case there are folks in the audience who don't know what PrEP is or how it works. Maybe I can start with Dr. Ramone. If you could just give a brief description about what PrEP is and how does it work?
So PrEP, as I'm sure most people are aware, actually stands for pre-exposure prophylaxis. And this is a strategy in HIV prevention, specifically where one takes medications to actually prevent infection. So that's really, in a nutshell, what PrEP is. And we have been doing this and not even calling it PrEP for quite a while, because if you remember, our knowledge of HIV transmission is quite voluminous, and we started actually realizing that by treating the individual with the infection, we can actually prevent transmission to sexual partners. So treatment as prevention is something that really informed us significantly about the ability to actually prevent infection. Now, you also remember that we were giving and found very early with trials going back to the early 90s, 076 is one that most of you may have seen, where we were looking at whether we can decrease transmission of HIV from mother to child. And we actually were giving the moms who obviously needed treatment, but in doing that, decrease the transmission to the baby, and even the baby after they were actually born. Even up to today, we are still giving them about 6 weeks of medication, which you can say it's not pre-exposure, but post-exposure, which I hope most of you are aware that there's also PEP, which I just described, which is if one may have been exposed, taking medications to prevent. Of course, here time is of the essence. So it has to be done really as soon as possible, preferably within 72 hours to really decrease the risk of getting infection. So that's PrEP and PEP. And in terms of the medication for PrEP, there's actually 2 medications that currently we have approved for PrEP. The first one and the initial one is a combination, and both of these are a combination of 2 medications. The 2 components of Truvada, which is the initial medication that was approved back in 2012, after there was evidence from randomized clinical trials where obviously we had people not taking the medication and some taking the medication, all being advised to still continue using safer sex practices, actually revealed that there was a marked difference in the prevention of infection in the population that was taking the medication that could not be explained by chance. And therefore, the recommendation made, of course, safety is important. The safety indicators were also such that there was no really worrisome alarms. It doesn't mean there are no concerns that we need to educate patients about, and we can answer some of those. That's what we've been using up to actually last year, when at least for the MSM and transgender patients who are, males who actually are having sex with males, we actually have Descovy, which I think most of you are aware is very similar to Truvada, except because of one of the concerns we had with Truvada, which was related to the TDF component of the regimen, or the Viriad, which is a name that you may all be familiar with. There was some bone and also kidney concerns. Not that the medication caused kidney failure, not by any means, but definitely there were some concerns about that from our HIV use of that regimen in treatment, and a safer alternative being available, and that's called TAF, or tenofovir alafenamide. So really our chemists kind of modified the molecule so that what really happens with TAF is that the tenofovir, which is the real drug that is doing the work here, is more in the cells that we need to protect against HIV infection than in the blood. So there's less tenofovir circulating in the blood, and therefore less going to the kidneys and the bones. So we decrease that toxicity in the long term. For our heterosexual, patients, particularly females, at this point, there are studies ongoing to actually really show that we are not having any less protection with Descovy in our female patients compared to what we have seen in the male patient population. So those data will be actually forthcoming most likely this year, but there's a big international study still looking at that. So I'm gonna stop here because I wanna make sure people will have an opportunity to ask questions specific to how we use PrEP and some of these concerns that you may have, and the overall strategy in terms of managing patients on PrEP.
Yes, yes, thank you for that detailed explanation. I'm going to second the doctor's message and encourage everyone to ask their questions in the chat box or make any comments that will integrate. I also just want to drive home sort of what it looks like to be on PrEP. So Alister, if I could come to you, could you just talk a little bit about what the regimen looks like? How long does it take before your body builds that immunity? Just a little bit more about the details of getting on to PrEP.
Sure. So as far as how long it takes, it really depends upon the individual and the body tissue. It can take 1 week up to 3 weeks, but I think that it's an important thing to know that you can't just take PrEP one day and immediately have protection. There is what's called PrEP on demand, where you can take it up to 72 hours before that you might need it. But again, it's everything taken in advance. Usually it's 1 pill a day, once a day, every day, monitoring through lab. So that does mean that you're going to have to see your doctor at least every 3 months, something good to keep in mind. And I mean, besides that, there's side effects that come up in the first couple of weeks, but they usually dissipate. The side effects that Dr. Ramone was talking about, that's why you have to go to the doctor and get your lab. So if one of these things does happen, you would know about it. And it's highly effective for the people who take it, and treatment is prevention. Thank you for saying that.
Awesome. Thank you for elaborating and getting to a place of protection, not immunity. I misspoke. But Dr. Ramon, before I could open it up about some of the particular problems that demographic groups face when trying to get access to PrEP, can you talk a little bit about where the state of Brooklyn currently stands with regards to PrEP uptake, a little bit about the progress we've made and some of the challenges that still exist to get communities such as Black men who have sex with women or people of transgender experience, give them more access to this medication.
Absolutely. So I think that's a good segue into really answering the question as to where are we within really the bigger picture of ending the HIV epidemic, which obviously part of it is HIV prevention. And I'm going to start with really the national picture with respect to the goals of actually increasing PrEP use in the at-risk populations by at least 50% by 2025, which is less than 4 years from now, right? And I think there are a lot of information that we have. So let's start with the progress that has been made. We actually have forums such as this that have really helped in terms of the grassroots movement in making sure that the population is educated about PrEP. So education is a key component, and there's quite a lot of organizations that needs to be commended on having taken this aside from the Department of Health in the country in making sure that their population is made aware of PrEP and addressing some of these issues, including some of the barriers that people have towards PrEP. So I think the biggest progress is once there was approval of really this strategy, then that meant most insurance companies would cover the medication, because obviously if this is an out-of-pocket medical care, it becomes an obstacle. Second, it was making sure that even those that are uninsured, at least in New York State, that they can actually still be eligible for PrEP, even though they don't have coverage. So I think those two in terms of access are very, very, very important. Now, there are payers, including Amida Care, that not only cover, but also really proactively are educating the communities about PrEP and really the places that they can get PrEP. We have nationally organizations that have made it easy for people to actually find out in their local area where they can actually get PrEP, and even tracking the numbers of HIV infection in their areas. And this would be places such as ACEView, which really provide a lot of data, even though it may be a little bit behind in terms of more up-to-date information, really depending on how well they get the data. So currently, there are an estimated 1.2 million Americans who are eligible and would likely benefit from PrEP, and only 18% is estimated to be actually on it. So we still have a huge number of people who are eligible to be on PrEP not using it. When you narrow it down more specifically onto the Black and Latina individual who, as a reminder to the audience, account for about 69% of new HIV infections in the US, the numbers on PrEP don't reflect that at all, where we have actually 69% of actually about 66 to 69% of those initiating PrEP for the first time are largely not Black or Latina. So they are really largely white. So there's a huge underrepresentation of the populations that are at the highest risk in terms of uptake of PrEP. So I think the need for HIV programs that are actually locally tailored and looking at some of the socioeconomic determinants of health and, unfortunately, barriers to accessing not only the information, but also the places where they can get the information and the actual prescription counseling for PrEP are very, very important. So I think that's where we are in Brooklyn in particular. We have an even less uptake of PrEP compared to those national numbers that I kind of gave, where we are actually having a huge problem with one, where people can get PrEP. We have organizations such as SUNY Downstate that have a good program. We have one here, but I think the programs may not be well known to the community, and also may also be perceived maybe as not being as friendly to transgender and others. But that has tremendously improved in the last few years. And I'll give an example of our own program here. So we're in Brownsville, which for those of you who are aware, really is closer to downstate. We have had since 2014, when I came here, an increase in PrEP uptake where we have really upwards of 50 people on PrEP, and that's a very small number relative to the number of people that we need. Majority of them MSM, but we have about maybe 20% that's actually women and heterosexual males that we are also trying to increase PrEP on, because PrEP is not only for MSM, but also for heterosexuals. And we are seeing an even bigger gap for the heterosexual population at risk in terms of actually being aware of PrEP and actually accessing PrEP, and even when they do go to their primary care providers, not being able to get it. And that brings me to the next point, which is we are trying to integrate HIV prevention into primary care. And this is a national strategy, and New York State is actually on the forefront here by educating primary care providers to be able to, one, know how to take a sexual history as part of health and not making it any unique or, well, we have now to talk about sex. Well, should be in the same discussion that we are talking about the diabetes or anything else that we talk about in primary care, and not necessarily because of any biases that we have as providers. So that education is ongoing with the ultimate goal of making sure that anyone who walks into their primary care provider can be able to comfortably know that they will get one accurate information and actually get a prescription for PrEP if they choose to do that. So that's ongoing, and we have a lot of providers that are interested in this, but these are some of the challenges that I think are making the uptake a little bit lower. And I look forward to hearing what are some of the specific obstacles that some of the audience may have in accessing PrEP in Brooklyn.
Thank you so much, Doctor. That also is a great segue. Jawanza, I'd like to come to you to get some perspective about why, if you could talk more about these challenges, particularly as it relates to Black and Brown queer men who have sex with other men, a little bit about stigma, that information gap, like what you're hearing and seeing on the ground, and how we could develop solutions to sort of curtail those barriers.
Yeah, so I think that Dr. Ramon has laid out really a lot of the barriers. And, I really thank organizations like Amida Care for doing the work to make sure that people know about PrEP and have access to it, and also creating the sort of conditions where trans people and people of, trans experiences can feel safe and welcomed, which I don't think we should ever take for granted that that's a reality, that organizations go through a lot of work to make sure that they're creating a space that is welcoming to the people that are in most need of access to PrEP. So I don't really want to repeat any of the things that Dr. Ramon said, I think that are, legitimate barriers. But I do want to sort of take a step back and bring up the scope of our analysis and think a lot about the range of social determinants of health that we have to consider when we're thinking about PrEP. I think in the same way that we talk about housing as healthcare for people living with HIV and treatment being prevention, I think in order, one of the primary reasons why we talk about housing stability for people living with HIV is so that they're able to maintain their HIV/AIDS, regimens, consistently, so they can achieve a viral suppression. And when that happens on a community scale, to achieve community viral suppression, which means we're then going to be able to prevent the development of AIDS for people that are living with HIV and prevent new HIV infections, because that's what happens in moneyed communities, and communities that have access to the kinds of services and the kinds of treatment that we're describing here that folks need. And namely, those people are the people that have access to resources, including stable housing and also access to healthcare. So we talked a lot about the fact that just because you have access to the pill does not mean that you have access to comprehensive healthcare. So I think that any conversation about expanding the use of PrEP and making sure that all the people that need access to PrEP have access to it means that we need to be talking about expanding access to healthcare and comprehensive healthcare, including mental healthcare. So that means we need to be having conversations about Medicare for all, or on the New York state level, we need to have conversations about the New York Health Act, making sure that we can create a single payer healthcare system that allows all New Yorkers or all people living in the US to access comprehensive healthcare services. And we need to be talking about housing and housing stability. So I think that the vast majority of people that I come into contact with that are, in high risk groups, so, men who sleep with men, people of the trans experience, people experiencing homelessness, people engaged in, multiple sex partners, all these kinds of different behaviors, which I also want to take a step back and remind people that people's proximity to HIV oftentimes has nothing to do with their sexual behaviors or their drug use. It almost always has to do with their proximity to HIV, connected to poverty, connected to housing, lack of housing access, lack of access to comprehensive health care, which includes education, because we get educated every time we go to the doctor. And I think that those of us that have been insured for most of our lives, I had a period of time, the time that I contracted HIV, by the way, where I did not have healthcare coverage. And, I had no idea about a lot of basic things, like even the fact that PrEP existed. I don't think that, one, that most doctors necessarily know about PrEP or are going to think that it's something that they should be sharing with their patients, if the patient even has access to said doctor. So I'm saying all of that to say, in a nutshell, that we need to be, we have to hold the complexities of the issues that are happening. We have to understand why people's HIV or why people's proximity to HIV is so close and connected to poverty. And we need to be addressing those issues while simultaneously making sure that people have access to PrEP. And of course, we have to talk about HIV stigma, which is a very real phenomena that I personally deal with sometimes. But I think that the stigma issue is, I think it takes second place to economic security, social security, because at the end of the day, the folks that are contracting HIV in mass numbers, in particular Black and Brown folks, I believe it's because of the social determinants of health, and lesser because of stigma, and more so because of lack of access and continuity of access. That's what I think.
Sorry, I was on mute, but that makes a lot of sense. Talking about how this is all situated in a larger context of income security and housing security. Alister, I'd like to pose like a similar question to you, but talking about people of trans experience and some of the particular challenges that they may face in trying to get access to PrEP.
Thank you. Yeah, I mean, I think a lot of the factors that impact access for trans and non-binary folks really have been laid out. A lot of that looks like access to resources and social determinants of health, the environment of provider offices and health plans, if it's a space that trans people feel safe going to, or is it a space that I'm traumatized by, and do I want to return to that space? I think another thing that really impacts access is the studies and the interventions that we have. We have interventions that are done on one group of people and then applied to the trans community. There isn't a lot of information. We're not very good at collecting data to really capture trans individuals. So, even when we started our program, there's really not a good model of care of how to do that. So that's a lot of what we're doing, trying to get information about, have you heard of PrEP? If people are saying I'm not interested, why aren't you interested in PrEP? For trans folks, a lot of that has to do with hormones. That comes up time and time again. So gearing educational campaigns to dispel some of the misinformation and just make that information available. But you have to create a space that trans people want to enter. I was on a different panel and a trans PCP made a comment imploring providers, when trans people come to your office, be enthusiastic, be excited to see your trans patients, and like we really need to do that to encourage continuous access and to make sure that people are returning, right? Because we talked about, you need to make sure you're not having bad side effects and you're returning to have your labs done, and that's not going to happen unless we create spaces that are safe for trans people to access these vital health services.
Could I add a couple of things that I forgot to say that are really critical? I think also all of that what Alister said, but also we need to be talking about pricing, like price negotiations with pharmaceutical companies on the state levels, because these medications should not cost this much for our state program, like healthcare programs, to pay for PrEP access. That like a lot of those barriers that are happening politically that are preventing us from passing progressive policies like expanded, like we I don't know if people know about New York City's HIV/AIDS Services Administration, which only exists in New York City and not in the rest of the state. And people living with HIV also live in Rochester, Buffalo, Syracuse, Albany, Westchester County, and all the places in between. Yet they don't have the same degree of access to the enhanced economic assistance that folks in New York City have access to, which is really profoundly, I imagine, helped us, prevent new infections and also AIDS diagnoses. And there was one more thing that Alister reminded me of, which has just left me. Hopefully it comes back and I'll try to pop back in.
Whenever, and this goes to all the panelists, whenever you want to say something, feel free to pop in. I thank you, Alister and Jawanza, for detailing the nuances for particular communities. It also strikes me as this year becoming particularly challenging, given the pandemic and people having to learn and reorganize their services on the fly. And so this question is for everyone, but I'd like to start with Jako. If you could talk about how Brooklyn Community Pride Center has changed its service provision because of COVID-19 and how that's impacted the work of providing more access to PrEP or diminishing the barriers to PrEP.
Yeah, sure. Well, first of all, I wanted to add something to what Jawanza and Alister were also saying. I think also education and PrEP services need to take place at the same time as we are also addressing socioeconomic barriers and things like that, like homelessness and housing, etc. Workforce development, those kind of things that needs to happen at the same time. But in doing so, I think it's also really important to make sure that in reaching the people who need it and also reaching people of color, that it's very important that that everyone can also feel that relatability, right? And so I think it's important that those services are then also provided by organizations and by local organizations, by organizations that are led by people of color that have a really deep understanding of their own communities, of the communities that they work in, to also build that trust and to really make sure that people are being connected to PrEP services, right? So Brooklyn Community Pride, we're a local organization. We're serving the Brooklyn LGBTQ+ community. We're currently in one location on Fulton Street in Bed-Stuy, and in April we're also opening up an additional location in Crown Heights, Flatbush area at the Bedford Union Armory. So by going to the communities that need the services and we hope to be better able to reach folks, as opposed to them having to travel to Manhattan to distant locations where perhaps they don't feel they then do not recognize themselves. And so I think services need to be provided in the neighborhoods where people actually live and where they work. So we mostly do that through partners, right? So we work with the Latino Commission on AIDS because they know how it works, and we bring them into our office. They have an office here at Brooklyn Community Pride Center. Also working with Turning Point is also they work locally in Brooklyn, as well as other organizations. The Bedside Family Health Center here on Fulton Street. So that's how we mostly work, is through our partners in providing these services.
Thank you. I wanted to also just ask folks the similar question. Maybe Dr. Ramone, I could come to you. How has COVID-19 shelter-at-place orders?
Anybody hear me?
Hi, yes.
Hi, can I just say something about what you was talking about?
Yep, for sure.
Hi, I'm one of the first persons on Amida Care when it first started. And what I hear you talking about the LGBT community, but it's an overall base for people that I know, because I used to do outreach and living in the SROs. You get the information, but what it is that in those places is more like people don't care for themselves, that they need to understand that there's more services out there. And Amida Care, if they can come in and do some type of services and let people know that there's places to go and get help they know about the help, but in the LGBT community, a lot of them just want to get high because they're depressed, because they're not caring about themselves. They either stay on drugs and they boost and they live in these SROs because HASA send you to these places that they don't go in there and look at the severity of how bad it is in there. Some places are so bad is that some people rather live on the street than live in these SROs. And to get housing for some people, they're so comfortable with where they was and where they at, they don't know the steps and the means on how to take it forward to get better until you show them. Like I said, PSI helped me, and they gave me my life back, is to let me understand that living with AIDS, I was 19 when I got this, I'm 56. So I've seen everything. I've been through every medicine, everything there was. So I know what it is that when someone like Amida Care comes along, because when this was first founded, it was founded through the programs because there was no help, no health coverage for people who was HIV positive. And when they started this, it started through PROMESA, PSI, all of the programs started this foundation. And I was one of the first people who used to do outreach with them when it first started. They changed the name. It used to be a different name before, but you know, the services got much better than what it did. And that's why I love and I stick with Amida Care, because the level of care and love that they show for the client is awesome. But you got to also let the client, and the client got to also know that someone's really, because they used to have people come out to your house and speak to you and do outreach and let you know that they can, there's other services that you can get and that is there for you. Like now the pandemic is stopping a lot of that. It's stopping people from, like I'm in a hospital with COVID-19 right now. I almost died, you know, and you know, it's like, I love that Amida Care, they call me, they do the things that need to be done. They make sure things it's on point, you know, but a lot of people who don't know the services or don't feel that the services are there for them, they're not going to want it. They're not going to want to hold on to it. All they want to know is what they know is, you know, stuck in these places that they go in, they got to come in, they got to go, and all they know is that's their life, you know. But when a lot of places now is they're opening up programs, but they're making harm reduction. And when you do harm reduction, I'm sorry, a lot of people think I'm wrong for saying this, but when you do harm reduction, you're only still allowing a person to be and meet them and greet them where they at. But if you show them that there's a better way, like they did me, and show me that they care and show that, okay, if you're still getting high, we're going to send you to detox. We're going to help you. But by allowing a person saying, well, I'm going to meet them where they at, and I'm only going to let them drink one drink or smoke one crack or do whatever it is, they're going to continue to do that. They're going to continue to be where they at. And the crutch is, okay, I'm coming to this program, I'm coming to these services, but I'm only coming for one reason. I'm only coming to either get a Metro card, something that I can get from them that I can sell, or I can use to go back out and get high again. That's the only thing that's happening now.
Yeah.
You know, but the thing is, what I'm trying to say is that, you know, this service is the best service I think that's out there right now. You know, for a lot of people. But it's that a lot of people need to know about it. A lot of, you know, go to these SROs. That's where most of the people are at, especially in the transgender community. They're there. They're like 38th Street and 9th Avenue, 36th Street, the hotel, 174th Street or in the Bronx. That's one of the worst places in the world right there right now, you know, and you know, they just comfortable in there because no services come in.
Right.
Nobody come in and say, well, we're here to help you, to give you medical, to show you what we can give you, or give you something, or even tell you there's a place to go to for like maybe a couple of hours a day to show some love. And Amida Care does that. Amida Care for me.
I love how you're centering love in this discussion and how, and it's obvious how much they care, and by the way that you're describing the care that you receive from them. And I appreciate you being your candor and willingness to share with us in this context. I would like to, Alister.
Can I add something to that, or just?
I will go. I was going to go to Alister, and then I'll come right to
you.
Jako. Alister, I know you had your hand up.
Yeah, oh, I just wanted to add quickly, first of all, thank you, Daryl, for all of that, for being with us since the beginning. And I just felt like that was the perfect segue into talking about how COVID has impacted our services, because we do have, it's kind of a mouthful, external care coordinator specialist and also field outreach workers, and all of that has stopped since COVID. So we're limited to telephonic outreach, and you're right, we're a small plan, and if people don't know about our services, that doesn't, help people. So for Amida Care, COVID has dramatically impacted our operations
Yes,
and the reach that we have.
yes.
And Jako, thank you, Alister.
Yeah, I think it's Daryl. Thanks for bringing it up, because that's I think that is one of the impacts of COVID-19, is that the personal, really the personal connections, making the ability to make personal connections and really showing care has been significantly reduced because of COVID-19. Online, connecting online, it's just not the same, right? You miss a lot of the dynamic of being with someone in person and really showing the care. So I think that's a very that's one of the impacts that COVID-19 had, that we're doing everything online. So fortunately now that things have opened up again, it is possible again to, of course, to go to your to see your doctor, to go visit here at the center, for example, and be with people. But it's a very important aspect in how PrEP, in this case PrEP, then, right, is being rolled out and being provided to the community.
Yes, thank you for that insight. I want to take this opportunity. We've been talking a lot about what is PrEP, how does it work, and particularly situating it in Brooklyn communities, assessing our community throughout Brooklyn. Like I mentioned at the beginning, this is a part of a multiple town hall series. We're co-sponsoring New Pride Agenda is with Amida Care. And I see there are folks from other boroughs on this call, which is great. But I do want to keep a programming note that we'll be going to other boroughs like we are here in Brooklyn, organizing folks around the same topic. And so we hope to see you guys joining us in future virtual town halls. And we have a sort of a group activity to try to make this more interactive. We've been talking a lot about the details and amazing perspectives about how this should be viewed through a holistic lens. And now I want to take 2 minutes. It's a quick poll. Sort of before we get to the group activity, I'd like the attendees to take an opportunity to fill out the poll, sort of a testing your knowledge. It's true or false prompts. And so based on the prompt, you're just gonna say whether you agree with it or don't. And then after 2 to 3 minutes, as a group, the panelists will go through each of the prompts. And so sort of checking our knowledge before we get an opportunity at the end to discuss a few audience questions and then last comments from the panelists. And so the poll should be live. You guys should see it now. So just please take 2 to 3 minutes to fill this out. Okay, so we'll give it about 20 more seconds to get your final answers in. Cool. So we're gonna end the poll. And I'll share results so everyone could see the results for each of these questions while we present through a slide their actual correct answers. And so just waiting on the slide to come up. Awesome. So the first prompt is true or false. PrEP makes individuals more promiscuous. That's false. Nothing in PrEP chemically makes individuals more promiscuous. And so, Alister, do you mind taking the next one?
Yeah, no problem. True or false, PrEP can interfere with hormone replacements. So that's false. There haven't been any studies that have shown this to be true. It is a common misconception and concern that folks have. So thank you for including it.
Awesome, thank you. Jawanza, do you mind taking 3? Once you start PrEP, you can never stop.
Yeah, I don't think that's true. I think we start PrEP whenever we are at high risk of contracting HIV. And if circumstances change, then one can stop taking PrEP.
Cool, thank you, Jawanza. Jako, I can take PrEP only the day I know I'll have sex. True or false?
Sorry, I was on mute. That's actually false. You would have to start taking PrEP in advance for a period of time to build up the immunity, or so you have to start taking advance.
Thank you. To build that protection, yes. Dr. Ramone, number 5, I don't need to wear condoms while on PrEP. True or false?
So that will be false, because PrEP does not protect one against other STDs, only HIV. So, and in fact, this is the reason that we, the recommendation for PrEP does not include saying don't use condoms, have multiple sexual partners, or in general, you're taking PrEP, you can engage in high-risk behaviors. So that is false. And I think most people are actually aware of that. However, what we see happening is the knowledge that one is protecting themselves against HIV, for some people may actually be, the reason that they may do something that they would not otherwise do. But I don't by any means want to give the impression that there is any evidence that anyone who is taking PrEP, in fact, there's evidence towards the opposite, which is most people who are taking PrEP are serious about protecting themselves. So why would they then be putting themselves at risk for another sexually transmitted infection? These are people who are trying to really protect themselves. Yes, condoms are not 100%, and so a condom may break. Or again, based on the very important discussion we had that Jawanza spearheaded about some of the risks, not really having to do with behaviors, but rather the circumstances that one may be in, including something we haven't even talked about here, which is commercial sex work. And even, really where people are forced into having sex and is not willing, and they may not necessarily be getting paid for it. And the really negotiating of safety where the individual may not be in a position to actually convince their partner to use condoms, even though they want them used. So there are all of those things that could lead to someone who's on PrEP having an STI, not because they figured, well, I'm taking PrEP so I can do whatever I want. I'll get an injection to take care of the gonorrhea that I may get. And in fact, has been studies showing that there has been a significant reduction in STIs. The reason the numbers seem to be higher than what we used to see is because we are testing more. So people that are on PrEP, and I think there was a question here about forcing to see my doctor more often, that we can incorporate into this. The reason we see them more often. It's not punitive, but rather to make sure that we are not inadvertently giving someone PrEP who unfortunately already has HIV infection, because that then would lead to a suboptimal treatment of their HIV and development of a virus that is not being killed by medications and ultimately limiting the options that that individual has for treatment of their HIV, including not being able to take a simpler regimen because now we need to create a more complex regimen.
Right.
I want to also add, Ahmed, just for 1 second, the issue of really, I think the frequency of monitoring that most people are probably aware of, the 3 months visit with the doctor, that has actually changed. That if one is actually now established that they are not having any side effects on their PrEP, so this would be established within the first few weeks of them taking the medication, maybe even before they come back for their follow-up labs. Then it's a question of a honest discussion with the provider about, are they engaging in high-risk sexual behaviors? Who is their partner or partners? And in that individual who has a monogamous relationship with a partner who is HIV negative, let's start with that. Then the question is, has there been a discussion by the couple about the risk of HIV, which really we try to encourage, sex talk. I usually say to my patients, everyone is having sex, but nobody want to talk about it. It's like, all right, have you talked to your partner about the fact that you're on PrEP and the reasons why you're on PrEP? Because that's part of the education. I have educated you. Hopefully I've answered all of your questions. Spread the word. And the first person is the person you're having sex with.
Yes.
That way they are also informed. So the monitoring every 3 months is not written in stone. And in fact, to answer the question of how the pandemic has affected our management of PrEP, we are actually doing telehealth. And there are some challenges with that. In that, again, because of finances, people may not have phones that we are able to reach them at. And so aside from those challenges, we are able to refill the medications and actually have a patient come in to do blood work, or even walk down the street to an urgent care center that's convenient for them, instead of spending an hour getting to me and potentially getting exposed to coronavirus, and do the blood work and having the blood work actually sent to me. And that way we are able to make sure that there are no STIs that are untreated and that there has not been any exposure to HIV. So I think the education of the provider team, and I think the state has actually given even recommendation on treating partners for those patients that we have identified an STI without seeing them and legally being actually covered to be able to do that. So I think the pandemic has definitely caused a lot of problems, but if the provider really is genuinely interested in the well-being of the patient, there are all of these options that can be done to make sure that, one, the patient does not go unprotected and potentially wind up getting HIV, while at the same time ensuring that there aren't untreated infections, and most importantly, HIV, which obviously we don't want to partially treat it.
Right. Thank you, Dr. Ramon, for so eloquently explaining that. We also took 2 of the questions, and so we're efficient in that sense. I'll just go ahead and run through the rest for virtue of timekeeping. So number 7, PrEP has no side effects. That's false. We did talk about some of the side effects briefly that can arise. These range from like serious but rare side effects to more common and less serious side effects. And you should follow up with your provider or primary care physician to learn more about that. And lastly, PrEP is not covered by insurance and is expensive. That's also false there. It is covered by insurance. While there are definitely steps that we can take to make that coverage more exhaustive, there are pathways to afford PrEP if you have insurance and can afford it out of pocket. And so that's the end of the group activity. I know we find ourselves at 1 o'clock. It flew by because I was learning a lot from all the panelists and engaged in a lively discussion. I want to again remind folks that this is part of a continued series with Amida Care. And so we'll be coming to other boroughs across the city over the next few months, doing some similar discussions with community partners and doctors and local physicians. Also, New Pride Agenda, like I mentioned, is having its next virtual town hall on the 28th, where we're talking about state advocacy after the state budget's released. So please keep an eye out for that, more details about that. And we hope that everyone can join us for both of these events. I would like to take an opportunity to thank our star-studded panel. This has been super informative. I work in the weeds of this, trying to develop this, but I find myself learning new things every time people bring up ideas. We do have a resource slide that we want to put up briefly. And on this resource slide, you'll find links where you can learn more about Amida Care's resources, New Pride Agenda's programming and advocacy, and general New York City Health Department wide resources. And so you should find that on your screen right about now. And again, I would like to thank the panelists. And if anyone has any last thoughts they want to just say while the slide's up, it's fair game. I'm speaking to the panelists. Otherwise, we hope to see you in the future. And thank you so much for joining us on this Wednesday afternoon.
Yeah, hi, Ahmed. I just want to say, I echo your statements, but also to really put it out there that we are open for business at BMS. We are in the Department of Health building at 259 Bristol Street. And basically, we take all insurances, and in fact, don't care if one has insurance or not. We are an FQHC and have an obligation to provide care to those who are not able to afford or don't have coverage. And we would help specifically for PrEP, since Jawanza did point out that New York City is fortunate that we actually have things that are not available at our areas. We can actually assist the individual in getting covered for PrEP and not have to pay out of pocket. We even have a sampling program that one would leave potentially with a 7-day PrEP packet that they are not in any way left at risk. And we definitely look forward to having more out there in the community in terms of really marketing our services. But as far as HIV prevention, anyone and everyone is welcome. And we do have what I consider to be really a safe environment. And that's not my opinion, but really from the community of patients, including transgender patients that we now have in our practice for both HIV, but also for actually our PrEP.
Awesome. Thank you, Dr. Ramone. Any final comments from the panelists? Yes.
I've been wanting to say this for about 30 minutes now. I do want to say, one, this is a wonderful conversation. I deeply appreciate all the panelists and New Pride Agenda and Amida Care. And as a harm reductionist, I'd be remiss not to name that PrEP itself is harm reduction, and that harm reduction is simultaneously medical methodology and also an ideology where we think about people as full, comprehensive human beings. And drug use and people's housing insecurity and people's mental health care and mental health status ranges. And harm reduction is a person by person specific, sort of plan, a holistic plan that extends far beyond their medical plan. I think that any sort of assessment about harm reduction that sort of reduces the scope of what it means and what it is and what the practice is misinformed. I mean, we were literally talking about a harm reduction practice right now. So I think that, we should all be thinking about that, especially whenever we're talking about the very ideology, the movement of people that have produced the conditions for those of us living with HIV to have access to care. One of the biggest barriers that we talked about today, people having access to PrEP, is the knowledge of PrEP. And when we think about harm reduction, a person that I know very closely, who is a former drug user, once told me that, you know, harm reduction organizations are so critically important because perhaps the sterile syringe is the entry point to have a conversation about access to healthcare, about access to mental health care, about access to pre-exposure prophylaxis, about access to methadone and buprenorphine. So harm reduction creates many openings or many pathways for folks to walk through. It is not an enabler. What it is a reminder of what we're talking about and who we're talking about and what we're dealing with, and that no person is the sum of their issue. They are much, much more than that. And harm reduction as a practice, you know, as an idea, like steps forward with that idea. And when it comes to medical care, it implements and methodizes that idea. And I think that that's really, really, really important. That's how we got syringe exchange programs. That's how we got, you know, HIV drugs in our bodies before everybody had access to them. You know, it's the way that we are keeping people alive by the tens of thousands. It's a mutual aid practice. It's a practice that is a separate from the capital S state, and you know, increasingly lesser so. However, it's a really important idea that I do not want us to leave this meeting space thinking that harm reduction is somehow has no place in our efforts to make sure that everybody has access to PrEP.
Thank you, Jawanza, for adding that important caveat and insight. I think it's a good opportunity to say bye. This has been a lively discussion, and I enjoy every single minute of it. We've been over, and it feels like it's been 30 minutes long. I will say one more time, this is being recorded. And so if you go to New Pride Agenda's website, and I assume Amida Care's website, you'll find the recorded version of this later this week. So please share wide with your networks. And again, keep a lookout for more programming information from NPA. But once again, thank you, Jawanza, Alister, Jako, Dr. Ramone, and all of the attendees for joining us today. I wish you guys all a blessed Wednesday, and bye-bye.